Good evening and welcome to AUA's The Surgical Management of BPH and Updates from the AUA Clinical Guidelines live virtual course. We strive to offer outstanding educational courses and greatly appreciate your evaluations and general feedback so that we are able to continuously improve our programs. Before we get started, I'd like to go over a few items so you know how to participate in today's event. The AUA is accredited by the ACCME and designates this activity for a maximum of 1.5 AMA PRA Category 1 credits. Course handouts from the presentations have been made available to you. Please visit AUA University to access these handouts. Evaluations are very important to us. Course evaluations and CME credit will be administered electronically on the AUA University immediately following the live webinar. As we at the AUA continue to develop virtual education that meets your needs, we welcome your feedback regarding both the content and format of this activity. All persons in a position to control the content of an AUA educational activity are required to disclose any relevant financial relationships with any commercial interest. Please visit AUA University to view faculty and education council disclosures. The AUA would like to thank Olympus Corporation of the Americas for providing an independent educational grant in support of this webinar. Coding advice during the presentations are the opinion of the presenters and may not have been vetted through the AUA for accuracy. Please verify accuracy prior to reporting on medical claims. Please note that the course participants are prohibited from using or uploading content you accessed through this activity into external applications, bots, software or websites, including those using artificial intelligence technologies and infrastructures, including deep learning, machine learning, and large language models and generative AI. Finally, I'd like to extend a special thank you to our course director, Dr. Lori Lerner, for her time, talent, and expertise in developing this program. I will now turn the program over to Dr. Lerner, who will lead us in our knowledge assessment and introduce our faculty. Dr. Lerner?
All right. Well, here we are. So the activity goal, you can look this up on the AUA University. It's also posted there, but we're launching an educational initiative for those who are interested in the treatment of BPH. So take a look at the AUA University so that you can see if you're interested in this initiative and reading more about the different educational interventions. All right, here. I am on. Okay. So the learning objectives, I would encourage you to look at them. We're not going to go over them in depth, but the bottom line with this session for today, what we're really excited to talk to you about is diving a little bit into what we believe the role of the AUA clinical guideline is and get some information from our panelists in terms of how they use it. Look at some of the evidence base for some of the technologies. Obviously, it's quite broad. We won't go into all of them, but we will talk about several of them today, and how to interpret some of those clinical results in the context of patient experiences and other treatments, and how we sort of think about different types of treatments that are available in their mode of action, as well as some evidence surrounding that. I'd like our faculty, in which I'm very excited that everybody was joining us today. So the first of our faculty, going alphabetically here, Dr. Mandeville is a urologist in Burlington, Massachusetts, and is affiliated with Lahey Hospital and Medical Center. She received her degree from Tufts University. She's been in practice for more than 20 years and has expertise in treating kidney disorders, and particularly stones, and holmium laser enucleation of the prostate, did a fellowship in enucleation, and is one of my partners here in Boston. Dr. McClure comes to us from Weill Cornell. He has a unique training background in that he is not only a urologist, but he is also a board certified radiologist who's fellowship trained in vascular and interventional radiology. So he has expertise in imaging, image-guided therapy, and minimally invasive treatment of urologic disease in prostate, so prostate artery embolization. Dr. Jeremy Teo is currently an assistant dean and associate professor of the Faculty of Medicine at the Chinese University of Hong Kong. He is up very early, so thank you very much for joining us very early in the morning. Hope you have a lot of coffee. He is also the director of the Urology Center and director of robotic services. So he's an oncologic surgeon, but he also has expertise in benign conditions, especially BPH and aquablation. And finally, Dr. Carla Witzke is a general urologist in private practice in Michigan. She operates out of Mid-Michigan Medical Center in Mount Pleasant. She treats a wide variety of urologic conditions in both men and women and is a high volume user of the temporary implantable prostatic device. So thank you all very much for joining us today. I'm very appreciative of your time and partnership as we've put together this program, which is going to be great. I'm pretty excited about it. I'm working on two screens here, so I have to figure out which is the one, which slides I'm advancing, team. So we're going to start here by talking for the first segment about the proper application and role of the guidelines. Did I advance that one? Can we go back? All right, bear with me, team. This is exactly what we have all talked about here in terms of managing slides. Okay, so what I think is important to understand about the guidelines. So different countries have created different sets of guidelines based on the methodology that they chose to use. For us with the AUA, and we first initiated the guidelines in 2016, the panel first came together in 2016, and we focused initially on the surgical management. And we put the first publication came out in 2018, and then there was so much happening in the surgical world, which of course is part of what tonight is about, that we did a whole bunch of amendments. And then with the medical management, the whole thing came out in 2021, and we've already had another amendment since the 2021 that came out last year. And I think understanding the methodology is really vital in terms of appreciating how to put everything into context with the AUA guidelines. And one of the things that I like to share with everybody is that we stated that the goal of the guideline is to provide a useful reference on the effective evidence-based surgical management and medical management of male lower urinary tract symptoms secondary to benign prostatic hyperplasia. So the evidence base that we used was looking at clinical control trials and randomized control trials that were published and indexed after 2007. So with each amendment, we expanded that out from 2017 to 18, 19, and so on. And then the data that we utilized for these statements are based on what the panel, which was a diverse group in the panel, felt were acceptably performed RCTs and CCTs. But in order to put everything into context to each other, we had to pick a common denominator. Interp was what was used, or sham. So we had studies that were based on what we were able to find of publications that actually related to TERP or sham. So when we think about that, it's important to keep that into context. So if it was a trial that was against something other than TERP or sham, it was not used for generation of the actual guideline statement. That said, it could be within the supporting text in any way we wanted. So we were able to pull in the supporting text to pull in any data that we wanted that we felt was important and valid. So I always encourage people to go in and to actually look at what was stated afterwards. And if you get onto the website, you click on the guideline, it gives you the supporting text. So those give a little bit more granular information and can pull out other things. I wanted to ask one of our panelists here, how do you feel when you're utilizing the guidelines, and like in what way do the guidelines, or do you find them helpful for you? Dr. Mandeville.
Okay, let's see. Can you hear me?
Yes.
Okay. I think the guidelines are important, particularly when deciding what operations are best for patients. I think this is where you can get things wrong, and not do the right operation for people if you don't know the size of their prostate, if you don't know the configuration of their prostate. And so I think the guidelines that talk about making sure you have appropriate prostate sizing prior to going into surgery is probably one of the more important things in the guidelines, so that you get the right operation for the right person, or at least give them the right options that work for them. And so I think that's probably one of the key components that I use in my practice every day.
Dr. Witzke, so in private practice, and we certainly see, so I work at a VA hospital, so my patient population is quite different. We all on this panel have very different patient populations. But in the private sector, with a lot of direct to consumer, messaging and advertising that comes out, do patients come in to you? And of course, they don't know anything about the guidelines, to come in and say, this is what I'd like to do. Do you use the guidelines in how you think about things, in terms of going back and referencing that?
Yes, yes, I do. And just as Dr. Mandeville said, I think it's really important when patients come in to use those guidelines, understand the size of the prostate, and really kind of help patients understand why they may or may not be the right patient, or I should say their body is not the right, their prostate's not the right size to have a procedure done. And when you explain that to patients, usually they'll understand that really you have their best interest in mind, and that you're just trying to do the procedure that will suit them. One of the things I was going to add was to adding some more questions. Behavioral modifications are really important when you're going through the guidelines, especially nocturia, making sure we're not missing something like sleep apnea, so that we're getting good results with patients, and just really going over a great medical history with them too, when deciding on what type of therapy is important for them. Yeah.
Yeah, and actually that's a perfect way to end this first segment, because I will tell you, when we created the guidelines, we focused on, you'll see, we're going to flash into that in the next slide, but we created algorithms, for people to follow. But when it came to things like OAB and nocturia, we've referenced other guidelines. So we had a lot of discussion about that. And, we've been asked about that. And certainly during my time as chair, how do we pull in, like an organization like the AUA that has multiple different guidelines, how do you pull in different groups of people that created their guidelines and meld them all together into one when those lines do get a little bit blurry? And I think that's some of what we've talked about, and the guidelines do mention at the end, about future directions. And those are some of the things that are definitely, we're getting more and more understanding about the physiology of the bladder and how it responds to obstruction from BPH. But you're absolutely right. In terms of, we know that there are other things that could play a role that may not have to do actually with size, may have to do more with compliance or elasticity and some of those other things in nocturia for sure. So absolutely, those are areas for us to grow things in our future. So you guys segued into this beautifully. So some of the things to drive home in this next segment that we're going to talk about is these particular statements. So we all say in urology that a post-void residual, we all think everyone should do a post-void residual, but not everybody has a bladder scanner in the location that they are, right? So you may or may not have it where you've seen a patient, but we do think that it is an important part of assessment in terms of following a trend. We cannot say that there is a particular number that should make somebody be alarmed, but it is definitely, something that we should follow the trend. Uroflows are the same way, but we can't tell everybody you have to have a uroflow. When they just got off the bus and they went in and went to the bathroom, you're not going to be able to get one. So what we want is to say, we want you to think about getting a PVR and following that trend. We want you to get a uroflow and follow that trend, particularly if you've done an intervention, to see how that changes things. And pressure flow studies, either invasive or the non-invasive pressure flow studies, those are ones that we say, if you have some diagnostic uncertainty, then that is definitely, you should consider, getting more information to help you. So looking specifically at that, we talked a little bit, Dr. Witzke, already about the algorithm, but so Dr. McClure, I'm going to ask you, when you're thinking about, you're an interventional radiologist, you're double boarded. how does imaging or understanding the size or shape of the prostate influence the decisions that you have when a patient is sent to you, right? Like which modalities should urologists be offering, or do you see patients that are sent to you that you say, maybe you should do something else and send them back to the person who referred to you?
Yeah, I mean, size is critical when evaluating patients for PAE. And oftentimes, to your point, people will come in wanting a specific procedure because they hear that you do it. And I think the guidelines are actually a great way to explain to them that this may not be the best procedure for them because there's other options. And with regards to prostate artery embolization, size really does matter. You know, if you have a small prostate, less than say 60 or 50 grams, then those patients aren't likely to do it as well. So if they haven't had a truss or an MRI, then I think it's important to get that. The other aspect of prostate volume or prostate shape is the presence of a median lobe. That's something that we pay attention to. There's early literature to suggest that median lobes might not do as well, but it suggests that they just have a rockier kind of post-procedure recovery. And their outcomes tend to be similar. But you know, if you have a large dominant median lobe, and it's something you have to be cognizant of when you're doing the embolization to make sure that you're seeing that on angiography. So there's definitely a role for understanding the volume and the shape of the prostate too, just when you're planning the procedure itself.
Yeah, for sure, for sure. And I think that is, we've gotten so much more granular in terms of what we've needed to do in that, because there are just so many technologies. When there was only one or two, some of that didn't matter. Dr. Teo, if a patient comes in with an indwelling catheter, like, so they've got a catheter, does that affect your decision-making, or is everything still on the table that it would be if the patient didn't have a catheter in place beforehand, or do you evaluate that patient a little bit differently?
Yeah, certainly. I think, we have so many different types of treatment. It's often the balance between the degree of invasiveness versus how radical is your treatment in terms of efficacy. So certainly, say for patients with smaller prostates, then we might think about doing resume urolift. But if the patient has retention of urine or even obstructive uropathy, then I would be more cautious in offering these options and probably would offer more radical treatment like TURP. And for bigger prostates, then certainly TURP, whole lab aquablation, these are good options. But again, if it's a very big prostate with retention of urine, then obviously we might lean towards whole lab. In order to have a good immediate recovery in terms of relief of the catheter as well as long-term efficacy. So I think these are the things that we must take into account and in order to have a more personalized treatment option.
For sure, yeah. And we'll go into this a little bit. This was going to be into the next segment, but you know what we're going to talk about here, because I see a lot of questions in the chat that are asking about that. And we are going to get into it a little bit more. But I'm just looking at my script over here, everyone, and saying about understanding bladder function. Dr. Mandeville, just quickly, what do you think about understanding bladder function? So looking at some of these chats that people have put in there and sort of what we're thinking about, and we talked about, urodynamics. When is it important, and when do you think you really need to understand that?
So for me, I've actually significantly decreased the amount of urodynamics I do in my practice. For everyone who came in who I had concern for hypotonicity, I used to get it because I used to think that maybe they would fail a procedure. But now in the setting of enucleation, and the data really does show that even if patients have hypotonic bladders, and I'm talking 0 centimeters of water for a detrusor pressure when they have their urodynamics, they still void, and some of it's gravitational, but you'd be amazed how many come in and they have a flow rate of 30 despite having a hypotonic bladder and they empty. I tell those patients, look, we can do a urodynamic study. If you want to be without a catheter or CIC, this is what we have to do. And there's the smallest infinitesimal risk that it won't work for you. And you may still need to catheterize, but if you want to be without one, I don't need the UDS data to support going forward. Where I do find UDS helpful is for the people with very severe storage symptoms. Those patients, I worry about their capacity. I worry about their compliance. I worry about whether I'm going to put them at a substantial risk for incontinence post-op if they have 110 cc capacity bladder and poor compliance. I'm sure we can get you without a catheter, but it may make your life worse in some ways. And those are patients who I may, depending on what their urodynamics show, consider intraoperative Botox at the same time as enucleation of the prostate. And those are patients who also, and I would say if you're going to do UDS on someone with a chronic catheter, it's sometimes a good idea to see if you can put them on a flip flow to get them to cycle their bladder a little bit, because sometimes the UDS will show that they have this bad capacity or bad compliance, but it's just a fact that their bladder's been so decompressed. So for me, really much more minimal use of UDS, and mainly for the severe storage symptoms is how I use it in my practice.
Yeah, and I would say this is our good segue into the next one, and looking a little bit in the chat. Somebody had asked about Eurocuff. So guidelines actually are not like differentiating between types of urodynamics. So the urodynamics and the AUA guidelines is all comers. It's talking about both invasive urodynamics and non-invasive, which should include Eurocuff. So just so you know, and we will try to answer some of those questions in the chat as we go. But I think that what Dr. Mandeville said and what Dr. Teo said is really important, is making sure that you're communicating the right expectations to patients. So they may be trading one problem for another, or they just need to understand. And so one of the things that we really wanted to drive home, as I alluded to before, is this idea of evaluating patients again after you've done an intervention. So whether it's a medical intervention or whether or not it's a procedural intervention, we think that you would see them back, see how they're doing, see how they respond, trend that PVR, trend that flow rate, get an idea of which direction they're going. And also, it's good for you to track your own results. So Dr. Teo, how vital is it for urologists to track their own results, both objectively with that flow and PVR after you've done something, as well as reevaluating patient approaches and selection?
I think it's very, very important, because clinical trial data and your actual real-world results can be very different. The patient selection can be different. And it's also important not only to learn about the final outcome, but to learn the recovery process, and how they actually improve with time is very important. And secondly, although we often follow the inclusion criteria and the trials in order to select which patients to undergo which treatment, but then I think a 30-gram prostate versus an 80-gram prostate can be quite different as well. So it's really a continuous process to learn about the minor or the small details on, for example, prostate size, prostate morphology, the flow rate results, in order to really select the most appropriate treatment. And of course, with continuous assessment, then you also can fine-tune your technique in order to have the best results in the future.
Yeah. For the statistical analysis for the guidelines, there had to be an IPS difference of at least 3 points and a quality of life difference as 1 point to show that there was efficacy to be included in the guidelines. And so the IPSS is another important component of what we need to follow when we're seeing patients back, to seeing if we've done an intervention. Now, this is when we talked about this, when we have these. Okay, there we are. Dr. McClure, how often do you counsel a patient regarding a secondary procedure or a return to medical therapy? You focus a lot on PAE. You have this unique thing, but what do you say to patients? Like, how do you talk to them about this after PAE?
Yeah, it's a great question, because there is some uncertainty about the longevity of PAE data. And when you see a patient, you counsel them, the key aspect, for at least for prostate artery embolization, that you want to follow them in their follow-up, like to your point, is their IPSS improvement. So if patients have a quick recovery and a notable IPSS improvement within 6 months, then you know that the PA worked. And if at 3-5 years down the road they have recurrence, then you can proceed with a repeat PA if they're interested in doing that. But if you don't see the robust improvement that you expect early on, then a repeat PA really doesn't make sense in that situation, then those situations, it makes more sense to refer, either put them back on medical therapy that they were trying to avoid, or talk to the urologist to talk about different treatment options. So it's really kind of the timing when that recurrence happens. So if it's an early recurrence or the symptom improvement isn't as robust as what you'd expect, that's when you suggest kind of looking at other options. If it's been several years and they have, slow return, then you can start adding medicines back again, or you can treat them again. And the PAE doesn't preclude you from having these other procedures done. There's many studies and many abstracts out there that have shown that PAE doesn't really make any surgery or any minimally invasive technique more challenging. And to that aspect too, prostate artery embolization after a hole up, or after whatever you have, if it's recurrent hematuria or anything like that, it's not more challenging a procedure for us to do from that perspective as well.
And I think that this is the idea, is that, it's important that we're at least communicating that to patients, because the thing is about these studies and what the FDA requires is that you report some things. It doesn't actually say what people have to report. And what we found in the guidelines when we looked at these trials, that retreatment rates are really influenced by the duration of how long they followed somebody. Do they follow them 12 weeks, 12 months, 3 years, 5 years?
Right.
And how complete it is. So, this does make it a bit gray, and we're not really comparing apples to apples. That is one thing. So as we segue into these pivotal studies, Carla, Dr. Witzke, you're going to bring us into this. If you have a patient who really wants something, we touched on this before, but the pivotal studies really sway them against that, and it could put them at risk for another procedure. Do you quote some of these studies, or do you feel that patients respond to some of these pivotal studies? Do the guidelines help you in that counseling for those patients?
So yeah, I think that it depends on the patient, first of all, and bringing things to their level. So some patients, I do think, especially if we're trying to really steer them in a direction when we know that they are not a candidate for minimally invasive procedures, their prostate's too big. And so using this data that we have is helpful for patients to make decisions. So I do find it helpful for the right patient, but some patients do come in with preconceptions, and it's very difficult to convince them otherwise.
Yeah, and there's a question here that somebody said, oftentimes patients ask about outcomes and failure rates and retreatment rates. So you will see, and actually I have been approached about this too, about this idea of real world data, right? So real world data is a big thing right now that we're talking about. I didn't really had talked to the panel about this before, sort of freelancing here, but that's the idea, is that when we are looking at pivotal trials, and how they've selected them, it may not reflect some of the actual real world of what people are doing out there, and if they're actually following the guidelines and the size recommendations and things like that. So, looking at some of these questions in the chat, patients will ask about retreatment rates and failures. And the truth is we don't actually know that in such a way, but there are more and more people publishing on that. But those can be harder to fund. Like, industry doesn't necessarily want to fund something or pit a whole bunch of procedures against each other, because I would think they stand to lose that. Now, some of them may be very willing to do that, but getting funding and research grants and everything is really challenging. So I think that we do have a responsibility to say, okay, well, when we are getting into a trial or a study, that we are trying to find ways to make these trials similar, and to have expectations that researchers say, okay, these are the standards by which you should look at BPH therapies, so that we can answer exactly those questions that patients ask. And quite frankly, it's what urologists want to know, right? They want to know, if they have patient X who has a prostate that looks like this, what are my options and what are the right ones? I wanted to take this moment, because we were talking about the pivotal studies here, that they all are a little bit different, but legacy technologies was new in this last guideline, which we don't have new data on them. So it's harder to put it into the context of some of the new technologies coming out there, but the technologies themselves are not unsafe. We just don't have anything that met our criteria for inclusion in the guidelines. So we have now called those legacy technologies. So that is a new term for us within the BPH guidelines. So we're going to go back to that. Dr. Mandeville, so when we're talking about published trials and randomized controlled trials, you know, how HoLEP enucleation is the most studied of basically all the technologies, even TURP to a large degree, but TURP is often used as the comparator. So knowing that, you know, you're an expert in this area that has such robust information and sometimes a little bit conflicting based on experience, you know, how do these RCTs and clinical trials, you know, affect your decision making, and do they matter to you?
I think, well, they're important, first of all, because patients are smart and patients have access to the world at their fingertips on Google. And so many patients come in and they've read these academic papers and they know. So you have to know as well, because if they come in knowing more than you, you're not looking great. And then number two, I think it's important. I mean, it's shaped my practice as far as urodynamics, right? I stopped doing urodynamics on the suspected hypotonic bladders based on the literature out there that shows that these patients are going to void regardless. It also helps me guide them about, you know, reintervention rates, because there's pretty well documented reintervention rates for TURP and HoLEP. And it also keeps me on my toes to make sure that my numbers seem to stack up with what's out there in the reported trials. So I will go through with patients what the literature suggests that the retreatment rate for HoLEP is, which is extraordinarily low, and then I'll tell them what mine is, which is low. And then I'll go through them with what the literature reports as transient incontinence and permanent incontinence and what I see in my own practice. And so I think it is important. I think it's important to tell people what the data shows that's out in the literature, but also what you have in comparison to what that data shows. And also to be able to compare other technologies, because now everyone comes in and they say, well, I'm here to talk to you about HoLEP, but also aquablation, but also robotic simple prostatectomy. And I want you to talk to me about all three of them and what the differences are and what the outcomes are. So people are smart and you need to know, and you need to be able to talk intelligently about it with these very, very smart patients.
The last question, Dr. Teo, I'm going to put to you before we go into talking about each of them, because you also have the unique perspective as being trained in oncology. And in oncology, I feel like the trials are designed in a much more specific way, that it's pretty strict. You are going to follow these bladder cancer guidelines. You are going to do this. This is what we recommend in prostate. It's much more prescriptive than what it is in BPH. You know, do you find that it affects what you offer patients, having, you know, sort of a training towards a very specific set of guidelines?
Well, I think it can be quite different, you know, treating BPH versus bladder cancer patient. But I think that's the fun part about BPH as well, right? There are so many different factors that you need to consider, trial data, but also the actual real world evidence. And most of the time, patients do have an option, right?
Yeah.
They can actually choose what they want to do based on the recovery process as well as the long-term efficacy. So I think it's actually quite okay for me, you know, to take these things into context and actually offer an option, which they actually choose for themselves in a way what they want to do in the future.
That's actually a great point. I hadn't thought about that, because in oncology, we often tell them this is where you're going to go. And so it probably is somewhat refreshing to have them as part of that decision making and having them make a choice. So that's a very interesting perspective. Well, we're going to move in now. Thank you, everybody, for talking a bit about the guidelines here. We're going to move into each of our specific technologies with our experts here, which we are so fortunate to have, everybody. So to take us off, our double-boarded, decade-long trainee who is now in practice,
Yes.
Dr. McClure.
All right, so today we're going to talk about prostate artery embolization. This is a quick review. These are my disclosures, none of them relevant. So one second as I get this. There we go. So what prostate artery embolization is, as you can see here, what we're doing is we select the internal iliac artery and identify the branches of the anterior division, which here in the yellow, this is the inferior gluteal artery, and the blue is the pudendal artery. The blue, light blue and pink is the obturator artery, and the yellow is the vesical artery. And then we identify the prostatic artery, which is this green one, and take a small catheter, usually about 2 French in size, to select that prostatic artery and deliver particles, which are beads in the range of 200 to 400 microns in size, that embolize the prostate and shrink this down. It's similar to what women have if they have a uterine fibroid embolization. And then usually what we'll do is do a cone beam CT, which is kind of like a mini CAT scan at the time of the procedure, to confirm that we are just in that prostatic artery and not anywhere else, to prevent any non-targeted embolization. The prospective data is now somewhat robust and essentially shows the following. The first study was from Gao et al. In 2014. And it looked at about 57 patients who underwent a PAE, and then 57 patients who underwent TURP. And about 6 months, both improvements in quality of life with IPSS, quality of life score, peak urinary flows, as well as post-voyage residuals were equal, and it was maintained for 2 years. The issue with this study, however, was the fact that the complication rate was about 50%. When you look at what those complication rates were, they were actually including technical failures, clinical failures, as well as post-artery embolization syndrome, which is expected. And so when you exclude those, the complication rates were actually similar to what you see with TURP, and there was no strictures and no transfusions. The next study was from Carnival, and this was a little confusing study because it included a retrospective analysis within it, but the study itself looked at TURP versus PAE, and TURP outperformed PAE in that situation. They revised their technique with something called the perfected technique, and when they retrospectively looked at those patients, they found that the TURP quality of life equaled that with this perfected technique. But at the end of the day, this trial showed that TURP was superior to PAE with regards to improving IPSS score. But again, it is notable that there was a good score improvement, about 12.5. So it's greater than that 3 that Dr. Leonard was talking about. Izadi and all looked at PAE versus TURP. This is a 1-year study, showed similar improvements with both PAE and TURP. However, complications were much less with the PAE group, about 3 times less. And when you look at the type of complications that we saw, the complications kind of went in line with what you expect with PAE versus TURP. TURP had some strictures, had some retrograde ejaculation, whereas the PAE had some radiodermatitis, as well as non-target embolization as defined by the rectal ischemia. This is another trial looking at TURP versus PAE. TURP outperformed PAE as expected in this study. It was about a notable improvement, and this was 2 years of data. Less complications with the PAE group, and no evidence of incontinence, no strictures as well with the PAE group as well. So at the end of the day, the randomized controlled trials that show that PAE does improve the IPSS. However, it's more variable. It's not as consistent as TURP, and PAE has fewer complications rates. And the next question is, well, was that PAE just placebo effect? So IRs actually asked that question. This was a randomized controlled trial where they actually randomized patients in the IR suite when the prostatic artery was selected, which is kind of crazy when you think about it. And they randomized patients to sham or embolization. And as you can see here, there was some placebo effect in the sham arm, but it was more notable with the actual embolization. When you brought patients back to the angio suite to do a full embolization, those patients had improvement in their in their IPSS as well. The next study looked at patients who had failed medical therapy with prostate glands at least 50 grams in size, and they had failed tamsulosin, and they randomized patients to either PAE or combo to tastride and tamsulosin. And as you can see here, The PA outperformed the combined therapy. You had a mean improvement of about 10 points on the IPSS score, whereas only improvement about 5.7 in the combined group. And as expected, really no impact on the erectile function. Actually, an improvement in the score of about 8 points with the PAE group, where you had decreased outcomes with regards to the combined therapy. So PA is not a placebo, and it does outperform medical therapy. What about real world data? This is a study that looked at in Europe and England, looking at PAE versus TERP. And in the real world, you know, TERP outperformed PAE. TERP had about a 15-point improvement. PAE only had 11-point improvement. But the other, which is what we saw with the randomized control data, but also it shows that there's kind of less complications with the PAE, less retrograde ejaculation, 50% with the surgery group, only 20% with the PAE group. And then if complications did occur in PAE, such as non-targeted embolization or vascular injuries such as dissection or hematoma, these could be managed conservatively. Long-term data, not much studies on this. However, from like the two kind of grandfathers of the field was Pisco. Is this not advancing? There we go. So this was Pisco. He was one of the first people to really look at prostate artery embolization. They found that about 5 years, there was about a 20% recurrence rate. But it's important to realize that this is probably really underestimating the recurrence rates, because the cohort started at 1,000 patients and they're only looking at about a third with only 300 patients there. And then Carnival et al. Looked at their series of about 300 patients, again, a recurrence rate of about 30% at 5 years. And I think this is an important slide to look at, because it also shows the benefit of bilateral embolization. So that's something you want to talk about when you're working with IRs, is the percent success they have bilateral, because bilateral embolization, you have less recurrence than you would with unilateral embolization. So 5-year outcomes suggest recurrence rates of at least 20 to 30%. So the ideal PAE candidate, someone with moderate to severe LUTS, failed medical therapy, or someone who doesn't want to take medicines. Hematuria prostatic origin is very, very useful for non-surgical candidates, and ideally in prostate glands greater than 60 or 80 cc's. And I think it really highlights the uniqueness of our specialty in medicine and how it's evolving, where we really need to rely on the expertise of each and everyone's specialty. And so when you're working to partner with an IR, I think it's important to ask who's doing it, and you want to identify a champion or champions within that group. You want him or her to be the one person who's doing it routinely, so they're comfortable with it, because it's not the most straightforward procedure and it is somewhat technically challenging. The other thing you want to ask is what percentage of the cases are bilateral, and you'd expect to have people more than 80 or 90% bilateral. And then do they have access to cone beam CT? This is critical, particularly when people are learning this technique, because it really allows us to truly identify where that prostatic artery is, and it helps us prevent and be cognizant of the risk for non-targeted embolization. And then also, how do they manage non-targeted embolization, and what the workflow would be for pre and post embolization, both within clinics within IR and urology, because unfortunately some IR clinics don't have the same robust clinical support that we have in urology. This is a video of a prostate artery embolization. And so this is going to play. I'll just talk you through. So we get access with either femoral or radial access. How you do it, whether it's femoral or radial, really doesn't matter. Just the recovery is a little bit faster from the radial perspective, because you don't have to keep the leg straight for as long. And this is just an angiogram in the left internal iliac. And you can see here the gluteal branch is here. And then you can see the prostatic artery on this fluoroscopic image showing right here, okay? And what we do then is, once we've identified that, we'll do kind of a roadmap, which will show up here in a second. And this lets us guide the catheter into the prostatic artery. And the size of the catheters, to put in perspective, the base catheter is about 5 French, and then the catheter that we embolize the prostate with is usually about 2 French in size. Here's this wire we're putting out, and the wire is about 0.18 or 0.15 inches in diameter. And once we get in that prostatic artery, we'll then start doing the embolization. Now, there's 3 products that are FDA approved for prostate artery embolization. They're Embosphere, Embozine, and Hydropearls. I don't have a preference on any of them, but those are the 3 particles that are FDA approved for prostate artery embolization. And the size that we usually use for prostate artery embolization are beads that are about 300 to 500 microns in size. So the particle I use is more calibrated, so it's a single size. So if I have a prostate artery embolization above, or sorry, if I have a prostate gland that's above, say, 60 or 80 grams, I'll use 400 microns in size. And then if I have a prostate that's less than 60 or 80 grams in size, I'll use a particle size of about 200. But there's been studies that have compared prostate particle, or sorry, bead particle size to like smaller size versus larger size, and seeing if that improves the outcomes with regards to improvement in IPSS score. And those studies really showed no difference with regards to improvement in IPSS score, just they had a higher risk of adverse events. So the smaller particles, there's a higher risk of them migrating and going somewhere else and causing a non-target embolization. There's also a higher chance of them potentially giving you a post-embolization syndrome from that perspective. During the embolization, this is what we're looking at. We're looking at how vascular that is. So here you can see just underneath the pubic symphysis, you can see the prostate itself. You can see there's no accessory arteries to the pudendal artery or the rectal artery. And then under fluoroscopic guidance, we slowly inject this, the beads and contrast into the prostate. And as you'll see here, the prostate here is going to slowly become more stained as we deliver more particles and slow the blood flow down.
Tim, if you have, while you're talking about the video as you go along, I had 2 questions for you. You mentioned the non-target embolization, and if you see things like little glands, ischemia, how do you manage that? And there was a question in the chat about tissue sloughing that can occur with PAE, and how long does it usually last? So as you're talking through this video, that we would like to thank Prostate Centers USA for providing us with this video for us to show tonight, as well. So maybe tie that into your conversation would be great.
Yeah, so so basically non-target embolization would mean if it goes to the rectum or the bladder or the penis. If that happens, usually what happens, you just get an ulcer that forms, and it just conservative management, and that ulcer heals on its own. There's been case reports of really bad non-target embolization where they embolize like the pudendal artery, and you get like real deep necrosis of the penis. You manage it almost the way you manage like microcalcinosis in the diabetic patient, just local wound care. And then that tissue kind of sloughs off and heals on its own. To prevent non-targeted embolization, this video doesn't show it, but if you see arteries that are the prostatic artery connecting to the rectum or the pudendal artery, what we can do is place small little coils to block those those collateral blood flows, to just get blood flow within the prostate itself. So that's things that we are paying attention to when we're doing the angiogram, to make sure that we don't have that non-target embolization from that perspective. And then sloughing. So sloughing is a rare occurrence. It can happen sometimes. Just a cysto with just kind of scraping can clear that out. You tend to see it more often with people who use smaller particles. So that's a really rare occurrence, at least that in our experience. Here we've moved to the left or to the right side. This is showing the angiogram from the left common iliac. And what he's doing here is he's selecting that internal iliac that's coming medial. I'm actually going to move it up a little bit just in the interest of time, because it's not that.
And
Like-
also, there was, some of the people in our audience are not as familiar with what PAE syndrome is. So as you're talking,
Oh, yeah.
maybe explain a little bit
Sure.
about that. Yeah.
So prostate embolization syndrome is basically people present with, they may have worsening LUTS, so frequency, urgency, almost feel like they have a bad prostatitis. They may have a low-grade fever. They may have some blood in the urine, and that can last for a week or two, depending on how, basically depending on how vascular the prostate is. It's managed with medicine. My patients, I send home with a steroid dose pack, Iridium, and I give them either Cialis or tamsulosin to help help negate those symptoms, as well as kind of give them the scheduled Tylenol to help reduce the inflammation. But it's transient and it does resolve. This is just to kind of highlight the complexity of this, where you get lots of vessels that overlap with one another. So you really have to understand the anatomy well and understand tricks to get the prostatic artery out of better visualized. So here you can see it looks as though he's in the prostatic artery, but the real prostatic artery is this kind of question mark right here, and he's just not, the wire's not going where you need to go. So what he's going to do in a second, you shoot another angiogram, and you'd expect the prostatic artery to be here, but then it flows along here, which suggests that there's some overlap. So then what we'll do is we'll move the C-arm in a different projection, and then you'll see that prostatic artery coming across like this. And so just to put things in reference, say this blood vessel here was connected to this prostatic artery, or you couldn't get to this prostatic artery, and this vessel here was supplying the bladder. What you could do is get into this blood vessel here and deploy a small little coil that will block that blood vessel. And because it's so proximal, it doesn't cause ischemia to the organ that you're embolizing there. So you're not going to cause ischemia by putting a coil here, because you'll get good collateral flow from the other vessels that supply the bladder, but you'll prevent those particles from going down into the prostatic artery. And then here we're just using the roadmap technology to do this. Now, oftentimes in this situation, they're not showing this, but once you're in the prostatic artery, at least in my practice, what I'll do is I will then do a cone beam CT from here, just to triple check and make sure that we're actually in the prostatic artery and there's no collateral blood flow to the prostate. And I think that's something important that people need to be using when they're first starting to use this. So like new learners of prostate artery embolization is really incredible. It's really critical to have that access to that technology.
Well, Dr. McCord, this was fascinating. Thank you so very much for this section. A lot of the questions that we had, you answered right along the way and earlier, and we'll talk about more. But I think for a lot of the people who are tuning in today, this is really new and different for what we do. So thank you very much.
Of course. Thanks for the invite.
We are going to launch into a very different sort of approach for BPH, and this is with Dr. Witzke. So this is the temporary implantable nitinol device. We tend to call it IEND, but we're saying generic here. So take it away.
Okay, thank you so much. So we're going to talk a little bit and describe the temporary implantable nitinol device. Some of the benefits for patients are that it's a significant, rapid, and durable improvement of lower urinary tract symptoms. It also preserves sexual function, which is attractive for a lot of patients. It has no cutting, there's no energy, it's not a permanent implant, and it still allows for other procedures to be done if it is needed in the future. Ideally, the prostate would be between 25 to 75 grams. There should be no median lobe, and this is great for patients who have a high riding bladder neck. And again, patients aged 50 or older would be ideal candidates for this. Some of the contraindications to consider would be if your patient has an active UTI or prostatitis, if they have an artificial urinary sphincter or any implant within the urethra, prostate cancer, bladder cancer, neurogenic bladder such as an atonic bladder, If they have urethral strictures and if they have an allergy to nickel, this would not be an appropriate system to use, as this is composed of nickel and titanium. So we talked a little bit about the guidelines and the workup, symptom scores to get post-residual and uroflow. And it's important to have a measurement of the prostate. So whether that's if you have MRI available or ultrasounds, and to do a cystoscopy would be important for these patients, again, to make sure we don't have any contraindications such as stricture. Another important aspect with a lot of the minimally invasive techniques is to really set your patients up for success. So discussing expectations. So some of the common side effects will be pelvic discomfort. Patients often have blood in the urine. This usually lasts from 1 to 2 days. They can have urgency of urination. They might experience dysuria with the implant in place. Rare side effects from this are possible urinary tract infections or sudden difficulty with urination. Also, with patients, you're going to want to discuss with them to decrease bladder stimulation, talking about decreased caffeine and alcohol use. One of the questions that just came through was about testing for a nickel or titanium allergy prior to the procedure, and if so, how? So the answer to that would be to, as we do with most allergies, would be to ask your patients of that. Obviously, women tend to wear earrings that we might know a little bit faster than men. But if you could ask about jewelry, if there's any kind of jewelry that they've worn, and ask that question if they are aware of that. But to that question, it is a little unusual unless they've listed that to know if they have a true nickel allergy. But it is something to consider, because you wouldn't want to place this in a patient and really add to all of their inflammation and dysuria with this. Also, you want to discuss with your patients while they have the implant in place that they want to decrease their activity. So when they wouldn't exercise, for example, for that 5 to 7 days, because there is a stringing hanging out of the urethra, they should not have sexual intercourse during that time. And then to sit on a soft pillow, such as a lazy boy, versus sitting on a hard surface, such as a chair, as that may be uncomfortable with this in place. Some of the medications that can be useful during the 5 to 7 days: Tylenol, ibuprofen, or Toradol. I will usually prescribe Toradol if there's no contraindication. Pyridine is really useful for the dysuria. If you leave enough slack, which we'll go over once we go over the procedure, Oragel, you may not need this, but Oragel or Vaseline around the meatus is helpful to decrease that discomfort. And consider a prednisone dose pack. You could consider a narcotic as well, but I have not had to give a narcotic to any of my patients to date. And the MTO2 study, we'll go over the slide next, which compares this, but it showed a significant and durable reduction in symptoms and improved the quality of life for patients for more than 36 months following treatment. So the post-void residual was reduced from baseline by 59.2 mLs. Only 8.6% of patients required retreatment after 3 years. 4.8% require post-op catheterization, which we'll see is the lowest of the trials that we'll compare to. And then the delta max was improved by 7.49 milliliters per second. So comparing the 3-year data with the IEND, UroLift, and Resume, we can see again that the IPS score is pretty close with all 3 of the minimally invasive surgical techniques. The Qmax does have a superior results with the IEND. The post-void residual was in the study was found to be fairly significant compared to the UroLift and Resume. The retreatment rate was kind of in the middle, UroLift being the greatest retreatment rate. In the post-op catheterization, you'll see it was far superior to the other minimally invasive techniques. Again, at only 4.8%. We'll go through quickly here 3 patients. The first one is a 79-year-old male. Again, the prostate is on the smaller side, just under that 25 grams. But again, this is what you talked about, real world. Their AUA, or their symptom score, their IPSS, was mostly dissatisfied. The patient does take an alpha blocker and a 5-alpha reductase inhibitor. This is a picture of their procedure. So we can see that coaptation, no median lobe at the bladder neck here. Post removal, we see these nice grooves, which are important. This is what we find when we take the device out. We have these nice struts or grooves at the 12 o'clock, 5 and 7 o'clock position. And we can see these laterally at the 7 and 5 on this post-op. Uroflow, these may be a little bit difficult to see. I apologize for that. But this first patient, we can see their first Qmax, I'll just read this out loud, was 15 milliliters per second. And their flow time was around 26. Their post Euro flow showed an improvement again from 15 to 42. Their flow time was around the same of 28 seconds. But we see subjectively with these patients that their symptom score is 18, mostly dissatisfied, to, again, this is a month afterwards, already to 4 and pleased. Our next patient is an 84-year-old male with a symptom score of 20 and displeased. He's on an alpha blocker daily, and his PSA was 2.73. His prostate was under the 75 grams. We see nice coaptation there on the left side, interveculations in his bladder. His post-op removal, again, we see this nice open bladder neck with those deep struts or grooves at the 5 and 7 o'clock position. So his Uroflow procedure was 13. He did have a flow time of around 35. And his post-op, we'll see that his Qmax actually was pretty much the same with 13, but we did see a decrease in his flow time to 26. And again, we're going to see subjectively that this patient went from 20 down to 7 to mostly satisfied, and he was able to stop his alpha blocker at that 1 month post-op. And the last patient's a 78-year-old with a PSA, which was corrected to 4, with his prostate around 40 grams, with a pre-procedure of 18, symptom score, and mostly dissatisfied with an alpha blocker. His procedure image, and then his post-op, we're going to see here. Oh, I skipped over it. There we go. So this one, we can actually see that 12 o'clock strut, and then the 5 and 7 o'clock grooves as well. And on that right-sided photo, you can really see that nice deep groove there in that 7 o'clock position. And his Uroflow previous was 13, with a void time of around 58, and his post-procedure, his Qmax had actually gone from 13 to 29, and his void time had decreased to 34 seconds from 50 in the 50s. He went from, again, satisfaction of 18 down to 6, and he also stopped his alpha blocker at 1 month post-op. So now we're going to move on to our videos. The first one is an animation, and then this will go into a surgical video.
So as you're going through this video and as you talk about it, would you say, what is that shape? You mentioned that high,
The high riding bladder neck.
Yeah. And that can make a difference. But I was also noting on some of those patients that you presented, like that flow rate that they had pre-op of like 13 or 15, those were really good, like medical management patients. So I'm almost wondering if their outcomes are even better than somebody who maybe has a flow rate of 2 or 3. Do you find that people with that moderate obstruction tend to overall do better? Do you have thoughts about that?
Yeah, I think that they do. They do better with that. Yes. So what we're looking at, this is not, you're not going to need any additional equipment. You can use either a rigid or a flexible cystoscope with this. Most of these I'm doing in a surgical cysto suite. They can be done under some sedation if you're able to do that in the office. But you can see that basically we're using the cystoscope, we're going through the sheath, and then we are putting the optics back in, taking a look, making sure that our system's in the correct spot. And then as those 5 to 7 days go through, we'll see that reshaping that they're going to show here in just a second, which opens and expands through that 5 to 7 days. And then the next portion of this, which we'll see here. So we see that nice opening at that 12, 5, and 7. And then this device removal, again, can either be done in the office or under some sedation. And you can use a catheter. I use an access sheath to do this. And we're just placing this over that suture and going right over to the hub of the device. You do have some tension on that string, and then you're just kind of collapsing, pushing forward and collapsing that down, and then just taking it out in one even, gentle maneuver. And we can see the before and after of the pressure necrosis from the device. One of the questions here, I'm just going to do this real quickly and then I'll answer that question here. So this is kind of the outside view of how this works. Again, in a cysto suite. So under vision, you're going to pass the cystoscope into the bladder. So we're kind of going down to straight through to the urethra to look at the bladder neck. This actually, to answer your question, Dr. Lerner, this shows us a nice high riding bladder neck on this patient. That's our example here. So of course we're making sure there's no strictures, which we would have already done our cysto in the office. We're going to make sure there's no, lesions, that there's not any foreign objects, any stones that are in our way. We're going to take the optics out, leaving our sheath in place. And as we do that on the back table, we'll get our device ready. So you have an assistant with you, and there's a little bit of like a starter that we're going to see here that we're going to place right into the sheath. And then you're going to place the device. So you're holding the starter in place, and then you're going to start to feed the device through the sheath. And as you get into the bladder, you will feel it release. It will actually kind of open almost like a pop. There's no sound. You can feel that kind of give. And then you'll just take that starter off, leaving the device in place. You'll hold on and then just take your sheath out, leaving, again, this in place, holding on, making sure it stays in place. And then you're going to put your optics back in. And we're going to take a look alongside the device, because now we want to get that anchoring device at the 6 o'clock position. So we're just going to reinsert and take a look. And this all literally will just take you minutes to do under sedation. So now we're looking in and we can see our device. And so what we're going to do is twist this around. Currently, there's actually a blue line at the 12 o'clock position. So that stays up and you know that your anchor is at the 6 o'clock position. But on this, we see that anchor, which kind of looks like a tongue downwards. And we can see that 12, 5, and 7 o'clock. Usually a 21 or 22 cystoscope to answer that question is what we're using for that. So now we're going to pull just real gently. We're going to all just take a look, and we're going to pull the device back just over that bladder neck, smoothly and gently, and place it over the bladder neck, right by the vero. We're going to leave it in place, and then we're going to remove our scope.
I wanted to ask you quickly, as we're at the end here.
Sure.
I have found that when the prostate's really short, that those patients, I worry a little bit about the device being more in the bladder than in the prostate. And I've felt like putting a Foley in those catheters sort of in those patients preemptively, because it keeps them from having irritation from hitting the dome of the bladder. And do you think that there's too small of a prostate for this? Any thoughts of that and a Foley?
Yeah, so I think that could be a possibility. If you do have a shortened prostate, that could be an issue. I know that I've heard that they're trying to come up with different sizes for different prostates. So perhaps, instead of going bigger, maybe considering doing this for smaller patients too, because it is such a nice, attractive, minimally invasive technique. And there's no implant that's permanent. A lot of men really like this compared to other minimally invasive surgical techniques. So now we're just watching a video of the removal. Again, this can be done in the office. This can be done under sedation. The keys to removing it are going to be to decrease friction. So you're going to see that we're going to use a lot of lubrication right through our catheter, or if you're using an access sheath, you're going to watch, he's going to put some more lubricant into the urethra before the catheter goes in. And again, just kind of smooth, holding some tension, having an assistant hold some tension. And again, just smoothly placing the catheter or the access sheath over. And this part is really a lot of feel. And the more of these you do, the better you get with the feel. But going over and kind of feeling that hit the hub of the device. And then just again, kind of holding the tension and sliding forward, collapsing down, and then pulling out all in one smooth motion. And it's out. And patients may have a day or two of bleeding after this, but they right away can see that they're doing well. Again, there's a low catheterization with this. It's very rare that I'm having to place a catheter in a patient. They do really well with this. Yeah.
Well, thank you very much. Oh, yes, go ahead. Did you have
One
something?
of the other questions was about migration. I think we kind of talked a little bit about that too. So, yeah.
Awesome. Thank you very much, Dr. Witzke. And please put some questions into the chat. We're here to answer them for you. We're going to move into Dr. Teo now to talk about high pressure saline hydrodissection, or the robotic water jet therapy, otherwise known as ablation. Take it away.
Sure, thank you very much. So my pleasure to talk about this robotic water jet surgery. So so basically this type of technology really utilizes a real-time image guidance with an ultrasound scan, understanding the whole prostate contour, and then try to have a surgical planning in terms of the actual template that the prostate tissue they want to ablate during procedure. And during the procedure, you should be able to identify critical anatomy. That is the apical part of the prostate. You need to really visualize the verumontanum and therefore protect the ejaculatory function during surgery. And it's something that we need to learn throughout the process. So I think one of the good thing about this surgery is that regardless of the prostate size, planning part is pretty much quite straightforward. And once you have planned it, then the water jet delivery is actually quite efficient. So even for prostate, which is really big, usually the water jet delivery would take a few minutes. And therefore, for big prostate, you might gain some benefit from a shorter operative time. The other thing is that by utilizing a high velocity water jet resection, then you also minimize the heat delivery to the prostatic tissue and also possibly to the periphery of the prostate, which might be important if you want to preserve a maximal erectile function as well after surgery. And in terms of the evidence, I think this is the most important trial that supports the use of robotic water jet surgery, which is called the WATER study. This is a randomized trial focusing on patients with 30 to 80 mil prostates, so comparing between water jet surgery versus TRP. And basically, they look into the symptom relief in terms of the IPSS. So basically, you see the darker line, which represents robotic water jet surgery. Then it's more or less similar, if not better, than TRP. Pretty much along the years of follow-up at 5 years' time. And on the right, you can see that there's also an assessment in terms of the ejaculatory function. So interestingly, after the robotic water jet surgery, actually the ejaculatory function seems to improve a little bit, but more or less remain stable over the 5 years following surgery. Whereas after TURP, then we would usually expect a worsening of the ejaculatory function. So this is something important is about the retreatment rate. What I want to emphasize here is that the retreatment includes both medical as well as surgical retreatment rate. And therefore, it's actually quite high after TURP, almost around 17–18%, whereas in robotic water jet surgery, is less than 5% at 5 years' time. Apart from the randomized trial, there are two studies which I think is very important. The middle one there is called the WATER-2 study. So it's a prospective multicenter single-arm study, really trying to see whether robotic water jet surgery works for bigger prostates ranging from 80 to 150 mil. And the study on the right is called the open water study because, as we mentioned before, clinical trial data and also real-world data can be quite different. And therefore, there is a multi-center study basically including every types of prostate, 20 to 150, and C, whether it's safe and also efficacious in offering robotic water jet surgery in these patients. And I think something quite interesting is that what we found is that regardless on the clinical scenario, whether it's a clinical trial data, 30 to 80 mil prostate, whether it's a single arm clinical trial 80 to 50, or even open water, that is real data, then the IPSS improvement across the several studies are pretty much similar. So I think this really highlights the procedure as a rather standardized procedure that you can visualize a prostate gland during the surgery. You can determine the amount of tissue being ablated. And also, as soon as you plan everything in a standardized manner, then the outcome is actually can be very consistent across different sizes of prostate gland. So there's actually an IPD, individual patient data meta-analysis, on the functional outcome. So I think by including all the patients' data, then the IPSS improvement is about 16 points. The peak flow rate after surgery on average is 20.5. What is most appealing to surgeons as well as to patients is, of course, the functional preservation in terms of ejaculation, almost 90%. Although when we do the surgery, we would realize that sometimes the patients still have ejaculation, but they also reported some kind of reduction in terms of semen volume. So it's something that we need to counsel our patients about it. Erectile function preservation is pretty much almost 100%, and continence preservation is 99.5%. One thing that is very important is about the hemostatic procedure after the water jet surgery, because water jet surgery, obviously there will be some bleeding from the raw surface, but more importantly is we need to identify whether there are any arterial bleeders after surgery. And as we know from historical data, that basically most of the arteries is located at the bladder neck. So it has become a rather common procedure is that after the water surgery, typically we'll go back in with a bipolar resectoscope and then look into the bladder neck, really trying to identify arterial bleeders at the bladder neck. If there's any, then we stop the bleeding. Then usually the hemostasis will be quite okay. And some of the surgeons would resect a bit more on the fluffy tissue, which we can discuss further. But basically, if you don't resect the fluffy tissue, it should be fine most of the time, because these fluffy tissue after water surgery is expected to slough off with time. But then some patients would actually complain about it, some soft tissue continuously sloughing off, and therefore some surgeons would decide to, rather than waiting for this to slough off, fluffy tissue slough off, then you might as well just resect some of these of the tissue, and hopefully to speed up the recovery as well. So with this focal bladder neck cautery, I think the transfusion rate is very low, 0.8%. And basically, it has improved the hemostasis part a lot by introducing this focal bladder neck cautery. Let me see. Yeah. So in some of the countries that have been practicing so-called same-day discharge protocol, so as soon as you stop the bleeding at the bladder neck, then most of the time hemostasis will be fine. If you practice same-day discharge protocol, basically we would have irrigation for 4 hours, and then we would reevaluate. If that's okay, we can discharge the patient with a Foley catheter. And then when the patient comes back to the clinic a few days later, then you take it off. So with this protocol, actually the rate of same-day discharge is actually quite high, up to 87%. And it's actually quite safe with almost 0 readmissions and also transfusion rate. And therefore, I think with the focal bladder neck cautery protocol, then pretty much the hemostasis now is well controlled. So I think for me, although I'm a oncological surgeon, but In Hong Kong, we have the opportunity to really see BPH patients and offer different types of treatment. For me, I think for smaller prostate, mild to moderate BPH, most of the time we can offer resume and also relief. For bigger prostates, we might offer robotic autojet surgery, whole lap. But I think the key is that I think in the future, as we learn about this new technology, I think TURP is really going to become less popular, and we should really embrace the opportunity to learn about new technology in order to deliver the best outcomes to our patients. So in summary, water surgery is pretty much like a standardized robotic TURP, not only aiming to create a pattern channel, but also trying to preserve the erectile as well as the ejaculatory function. There's high quality data to support the efficacy and also the functional preservation. To me, it's easy to perform, highly efficient, regardless of prostate size. The last sentence is actually one of the comment from my patient. So patient comes to me having baseline some degree of erectile dysfunction, wanting to have BPH surgery, and I told him, well, if you have erectile dysfunction, probably you have less incentive to do a robotic waterjet surgery. We can do TURP or other types of surgery. But this is exactly the answer. If there's a choice, why wouldn't I want to preserve my ejaculatory function? I might have ED, but I'm not totally having an absolute no erection. Then why wouldn't I want to preserve what I still have in time? So it's really something that points out the fact that it's not only about a surgeon's decision, but a patient's perspective is actually very, very important. So next would be a video that my team and I has prepared. Okay, I might need some help there. So, oops. All right, so this is a short video just illustrating about the waterjet surgery. So the patient usually will be put under general anesthesia, lithotomy approach. Basically pretty much similar to how we position a patient for TURP. So in aquablation, first we need to prepare the transrectal ultrasound probe. This is actually the handle for placing the ultrasound probe. Is actually can be inserted into the rectum, into the anus, and then you fix it in order to visualize the whole prostate. During the whole procedure, you can see now we can rotate the knot and trying to put towards the rectum to make sure that you can visualize the whole prostate. So it's a biplanar ultrasound, so we need to make sure that we can cover the whole prostate sagittally as well as transversely. And this is the actual water jet delivery device. So now we're trying to prime the device, making sure that there's no gas bubbles in the tubes. And then we want to make sure that we can rotate the knot in order to retract the lens. So here you can see we're retracting the lens, and on top you can see the tip of the cystoscope as well as the water nozzle. And now we would insert the device into the bladder neck and then try to fix it to a holder here. So basically one holder on the left is for fixing the ultrasound. The other holder from the right is for fixing the water jet delivery device. And now we've fixed the device already, but we're rotating a knot. So you can see on the left, retract the scope until we just see the verumontanum. And my practice is actually go back in a little bit in order to make sure that we're able to protect the verumontanum. Then we'll try to visualize the water jet, because we need to know where the water jet nozzle is. So we need to let the system understand where it is as well. So you can see on top, there's actually two white lines there. This is actually the tip of the device as well as the water nozzle. So we tap on the pedal, you can see the water jet being delivered. It's like a test dose, and then we can try to calibrate the system so that the system knows where the water jet is going to come out. And then now we try to plan for the actual ablation template. So we try to retract the ultrasound until we see the maximal the widest area of the prostate, and then now we try to plan for the angle of ablation. If the patient has a median lobe, we can plan for an additional median lobe template. So now we're towards the bladder side, and then we can also plan for a specific angle and also the depth of the ablation for the median lobe. So if the patient doesn't have a median lobe, you can skip this part. And then the next part is to plan for the sagittal plane. So now you can see we are testing the water nozzle at the tip of the device. And then we need to mark this point so that the system know where it is. And then we draw a horizontal line towards the apical side. And then now we need to plan for the ablation in terms of the depth according to the sagittal plane. One thing very important here is to be more conservative over the bladder neck side, because that's where the artery is. So be more conservative also means that when you go back in, if you need to do some kind of resection to visualize the artery, it's easier. But if you go too deep at the bladder neck, then if there's bleeding from below and then it's already too deep, then you might not be so comfortable to resect further and then control bleeding. So now we're trying to plan for the apical part. So this is very important because you want to preserve the verumontanum. So you can see the orange zone is actually what we call a butterfly template instead of having a full swing. So the orange part is actually swinging on the right and also on the left, with preserving the central part, and that is the verumontanum. So after planning the transverse as well as the sagittal plane, then we deliver treatment. So this part is actually very efficient. Small prostate, big prostate usually can be finished in a few minutes time. So so now you can see the cystoscope part. This part is not so useful. I mean, the cystoscopic view in this part of the procedure is not extremely useful, but just to illustrate what is meant by butterfly clot just now. And then after the aquablation, then we would change to so after the first ablation, then typically we would go on to plan for a second ablation. Again, this is just a kind of a standard recommendation to go for 2 passes. But I think it depends on the context as well. If you have a very big prostate, one might to have a 3rd pass, etc. And then afterwards, then we can remove the device. And then what we typically do is to change to a bipolar resectoscope. And then obviously we need to try to do some washout, not only for the bleeding, potential blood clots, but also the soft tissue. Sometimes the tissues, fluffy tissue can also be washed out by ALEC evacuator. And then afterwards, then we'll try to do some resection over the bladder neck circumferentially to identify the bleeder, control it. As soon as you're comfortable with the hemostasis, then we can end the procedure. So now we've reinserted the cystoscope, and then we go back in, and then typically, this is not a usual type of food that we would see after, a TURP, because you see, this is what we meant by fluffy tissue. So what we do is inspect the bladder neck, try to do a bit of resection until you see a clean base. You identify artery, control it, and then typically, if you're just some oozing from the fluffy tissue, it's usually quite okay. Because just some venous oozing is not going to cause much problem in terms of bleeding control. It's really the artery that we need to be careful about. And afterwards, then we'll insert a 3 catheter. Typically, we would put the patient on irrigation, and then we would stop the irrigation after 4 hours or the next day. And then after 2 days, then we can take our catheter and let the patient go home. So I think this pretty much concludes the procedure. So I'll hand it over back to Laurie. Thank you.
There's we're running a little bit behind on time, but I did just quickly, because I think there's a lot to say here. In the chat, a couple of different things. One, I think it's really essential to understand ultrasound. I think people who don't really know how to read ultrasound, you need to understand ultrasound before you just dive into this. It's not up to industry to teach you how to read ultrasound. Don't rely on the reps. So I think you totally get that. And for myself, I've played with a laser and a loop and trying to find what I think is just the right thing. And sometimes I think if it's so intravesical, because the jet then pushes that tongue of tissue out of the way, you can get this like diving board of tissue. And so just could you comment on, I almost for me think that if it's so intravesical, I just enucleate. So a comment on that.
Yeah, I think that's a very good point. So having a very big intravesical lobe, there are two issues. Number one, the water jet delivery may not be as effective because, as you mentioned, it's like a tongue of tissue, almost like bouncing during the water jet surgery. So you almost always have to go back in and resect a bit more on the tongue part in order to avoid this kind of ball valve effect. And number two is, of course, although there isn't, I don't recognize any reports on actual urinary orifice injury or stricture, but I think it's a risk that as a surgeon we must be careful about, especially for intravesical lobe. I think with the tongue, then it's difficult to injure the urinary orifice, but you would expect, when we're going towards the blood side, then we have other options, and why not offer other options as well? So it's a very, very good point, I think.
No, thank you for that. I have had one where it was the middle lobe that came up behind the trigone, which we've seen, and it actually splayed up against the trigone, and that wasn't appreciated until afterwards. So, well, thank you very much. Dr. Mandeville, you are speaking of enucleation, since I was just talking about when I choose to enucleate versus aquablation. You are up next.
Okay, so I will make my presentation a little short because I know we're running short on time. I'm kind of the old kid on the block here. A lot of the technologies we talked about today are newer, but HOLEP's been around for a long time. And what we think of as anatomic endoscopic enucleation of the prostate, HOLEP was developed in the late 90s in New Zealand, and it combines the minimally invasiveness of TURP approach and the ability to obtain an endoscopically the same complete anatomic enucleation of prostate adenoma provided by a simple prostatectomy with maximal outlet deobstruction. And since the introduction of HOLEP, there's been many, many, many studies, multiple RCTs, and a large volume of level 1 evidence showing superior outcomes to TURP, green light PVP, or open simple prostatectomy. We've seen, and I'm not going to go through all the data for this because it's well known at this point, but we've seen holmium laser enucleation of the prostate compared to TURP. We have seen it compared to green light. We have seen it compared to open simple prostatectomy. And the data continues to show that it's far superior than many of these techniques for a variety of reasons. HOLEP, as we know it now, it is a size independent procedure, can be done for small glands, and it can be done for extraordinarily large glands. There's extremely low rates of transfusion, especially compared to the open simple prostatectomy counterpart. There's a very short length of catheterization and short hospital stay, and many of us are now going on to same-day catheter removal and same-day discharge, which is amazing when you think about doing the equivalent of an open simple prostatectomy through a scope and removing a catheter 4 hours later. It's pretty remarkable. And so what the key thing I think for HOLEP is that it's extraordinarily durable. Of all the procedures we're going to talk about, this is clearly the most durable, and the data shows this. This is from Dr. Krambach, looking at well over 1,000 patients. Now, some of these get lost to follow-up over time. But I think what the key thing we see here is the reoperation for regrowth was 0.1% over this 5-year follow-up. And we saw a very stable reduction in PSA, which also indicates, unlikely need for any reoperation for regrowth. And so I think, it's an important thing to talk to patients about when they want to talk about durability, that we do know that HOLEP is going to be thus far the most durable procedure that we have on the market. But HOLEP is not just for holmium anymore. There's a lot of different sources now, and people are using any laser that you can think about. So we have the holmium laser. You can do it with low power. You can do it with high power. You can do it with pulse modulation. There's the thumium laser, green light laser people are enucleating with now. There's the TFL laser, bipolar. People are doing enucleations with bipolar and plasma kinetic, and even diode lasers. So there's more than one way to skin a cat, and you can do it with all different types of lasers. So this has led to, even more data supporting enucleation of all types. We see good data on thulium laser, good data on simple prostatect, on green light enucleation, good data on diode enucleation, and good data on TFL enucleation. So really, I think it's more the technique than the energy source, but we do show good data for all of these types of enucleation procedures. So this is classic Gilling, Peter Gilling article from the BJU, which describes the original technique, which is a 3-lobe technique, which basically consists of incisions at 5 and 7 o'clock posteriorly, enucleating out the median lobe, and then going on to enucleate the lateral lobes. And you do this and divide at the anterior commissure so that the 2 lateral lobes come out separately. And so that's the 3-lobe technique. But this has evolved over time to 2-lobe technique, which is how I was trained and how I typically do it now. And also the en bloc technique with early apical release, where the whole entire gland is released as one unit. I think as long as your technique is good, most of these work quite well. To be determined if early apical release may be better than on the standard 2 or 3 block technique. So what improvements have come along for HoLEP? Well, so far we have pulse modulation, and that's what I'm going to focus a little bit on today. It's something that I use. Early apical release, and that's felt to help decrease the rates of transient stress urinary incontinence because you're decreasing the tension on the mucosa at the apex. And then miniaturization of scopes, so miniature HoLEP, and using as scopes as small as 18 French, which is crazy. And this is felt to decrease urethral trauma, decrease potential for stricture, and also possibly decrease damage to the sphincter. So we'll talk a little bit today about pulse modulation because I think the data for this is the most mature. Data for early apical release and miniaturization is coming to fruition, but I think the data for pulse modulation is pretty mature at this point. So what is pulse modulation? So Moses technology is the most common one you hear about from Luminous and Boston Scientific. So basically the laser pulse is modulated into 2 phases. The first phase separates water with a vapor bubble. And then in phase 2, you transmit the additional energy towards the target via the vapor bubble. And there's question as to whether this increases efficiency of energy delivery, and does it then increase surgical efficiency or hemostasis? There's also virtual basket, which is similar to this as well. So what does the data show? So this study out of Vanderbilt showed that when comparing standard HoLEP to Moses HoLEP, there was a reduction in total operative time and a reduction in enucleation time that was statistically significant. And it also showed that there was a reduction in hemostasis time, so time to obtain hemostasis after enucleation and prior to morcellation, and that was statistically significant as well. And it did not show any differences in the outcomes such as change in PSA, change in IPS score, and whatnot. So equally good results with that. And then we have another study here comparing Moses to non-Moses. This study did not show a difference in enucleation time, but did again show a reduction in hemostasis time, which was statistically significant. It also showed less use of post-op bladder irrigation, so indicative of less post-op hematuria, less need for CBI. And then this is a study, and again, their study did not show any differences in operative outcomes as far as IPS scores and quality of life and Qmax. Another study here using virtual basket mode, which again is similar, and this showed a reduction in operative time, which was statistically significant, and a potentially statistically significant decrease in hemoglobin. But again, whether that's clinically relevant it's probably not. So the data does seem to suggest that it does help with operative time and that it does help with hemostasis time. But recently we have another study coming out that shows that there's absolutely no difference. But I will say for this paper, they're using bipolar electric cautery for hemostasis at the end. So that does change things a little bit, also adds cost. So while the data is the verdict is still out, I do think that pulse modulation does help with hemostasis time and does help a little bit with enucleation times. So I think now we can go into the video, and hopefully I will catch us up here. So let's see here.
You actually are great because we're going to encourage people to put the questions into the chat. So
Okay.
you are all set.
All right, so this is a 100-gram prostate. This patient also had a large bladder stone. I am going to treat the stone prior to starting the enucleation, and you know, stone like this breaks apart pretty easily. I just use the standard stone dusting settings that we have with the Moses laser, and switch back and forth between dusting and fragmentation. It was pretty quick work of this, took about 5 minutes. I use a 7 French laser stabilizing catheter. I use a 550 micron holmium YAG laser fiber that's Moses compatible. And so we'll get the stone taken care of and get all the stone fragments flushed out, and then we'll talk about the technique. And this video is a little older, so I'm not doing the early apical release here because I hadn't started incorporating that into my practice yet. But I'll talk a little bit about that as we go on. Here we are looking for the ureteral orifices, and talking about ureteral orifices, you can see this right one is pretty close. It doesn't preclude us from doing the surgery, but you just got to be mindful of it. So I'm going to do the 2-lobe technique here. If I were to be doing the early apical release, I would do it a little differently, where I would just lift the apices up from the capsule and then release the mucosa apically circumferentially, but I'm not doing that in this video. So the first thing I'm doing is making an incision between the right and left lateral lobes. There's no significant median lobe here. I'm cutting down to identify capsule. Capsule, you can usually tell it's a kind of shiny surface with small little vessels that run over the surface of it, and you'll see that the tissue starts to glide nicely off of it when you are in the right plane. I generally tend to do low power HOLEP because I think, you know, less energy is better, in my opinion, as far as potential damage to the sphincter. But, you know, many people do it at 2 and 40, 2 and 50. I do it somewhere between 2 and 20 and 2 and 30 for my settings. And I don't really think that you need to do much higher than that, but you certainly can. I also like this video because it shows how transferable this technique is. You'll see that I'm doing the first half of the operation, and then my junior resident is doing the second half and doing it quite well. So now we are lifting the apex of the left lateral lobe off the capsule here. We're carrying that dissection up and around the apex, and I'm making sure that I don't go too far back so that I'm not getting into the sphincter. And you see I'm keeping that tissue on tension, pushing it into the midline, lifting it up off that capsule. And then a lot of the dissection is actually not cutting with the laser. It's actually a lot of the mechanical separation that we get. So now we're coming up and around the apex, and we're going to try to make our way all the way over anteriorly over the top of the apex, and then carry that anterior dissection towards the bladder neck. And you can see here, when you get into that sweet spot, that plane, the tissue really separates beautifully. Again, you use a lot of just mechanical separation as you push that adenoma away from the capsule. It really becomes very smooth when you're in a good plane. Now, of course, we show you our best videos. Sometimes the planes are not well defined, chronic prostatitis, chronic catheter, chronic infections, and this can actually be a lot harder than this video shows. So we're just continuing to dissect the anterior aspects of the right and left lateral lobe now off of the capsule. We're continuing to push that adenoma downwards until we want to try to come up and find the bladder neck. Generally, I'll usually enter into the bladder neck at this point, but I think I was letting the resident start to work. So we opted to divide the anterior commissure here. So basically dividing the prostate in half at the 12 o'clock spot. We'll carry that dissection from the bladder neck all the way to a point proximal to the viru, being careful not to go beyond the viru. I like to do with resident training a 2-lobe technique. I personally think it's easier for me to train them how to do that than as opposed to an end block technique, though many people say that they think end block technique is easier to teach. I think it's all kind of what you've learned over time.
I would agree with that. I actually, being a Peter Gilling, you know, from the very beginning, it's very hard for me to teach the end block.
Yeah. And so now we're going to have a little strip, what we call the mucosal strip. So this is, you know, because we did the 2-lobe technique and I did not do early apical release here. So there is a little strip of tissue that you have to cut. I'm pushing it in and away from the sphincter and making sure I'm not cutting into the sphincter. You can see I'm only cutting prostate tissue here, but some may say that that does put some additional strain or stress on the sphincter. So I have been playing around now with doing an early apical release, and we'll kind of see how the numbers shake out as far as transient leakage. That being said, this patient, I did not do an early apical release, and he used pads for about 2 days and didn't need them again. So, the data to be determined. So now we've made our way around the apices, we've divided the prostate anteriorly, and now we're doing kind of our posterior lateral dissection. And again, we're gonna make sure we stay in that plane, keep that tissue on tension, make sure we're always seeing the separation between adenoma and capsule, and then just carry the dissection all the way around. And you're gonna see here in a minute that my resident's gonna take over. Yeah, we have the plane set up for him, but really can do a really good job. You'll see there's a lot more pushing going on because it's someone newer doing it, but you see how beautifully these planes continue to show themselves to you. And so now we're kind of working our way to get underneath kind of at the 6 o'clock position, and we're going to start rolling this prostate tissue up and towards the bladder neck until we eventually get that whole lobe of tissue to roll up and through the bladder neck such that there's only a bladder neck stalk left. And so we're getting pretty close here. And again, a little bit more rubbing than I would do, but he's doing a great job. And you can see, I think with this, the first pass hemostasis with this Moses laser, I personally think is better. I did my probably first 500 or 600 using a standard 100-watt laser. And I've been using this laser for probably about 4 or 5 years. And I do feel the first pass hemostasis is better, meaning I'm spending a lot less time getting hemostasis after I've got the enucleation done. And you can see that here. I mean, you see how well those vessels coagulate. So we're almost getting this whole lobe up and out. And so we're going to get these last little attachments and get this thing freed. And then the last step will be is you got to roll those lobes all the way up and into the bladder so that you can morcellate them. One thing I've started adding into my practice is around 3/4 of the way through the enucleation is I will give a patient a dose of tranexamic acid. The data on that, whether you need it or not, is not robust. I do feel as though it helps helps keep and maintain hemostasis when they're in the recovery room. It's really pretty safe. There's very few contraindications for it. So something to think about. I've been playing around with that too. And I do think it helps with time for catheterization, time for irrigation post-op. But we'll see. There'll be more studies coming out on this. So
I think especially in this era of so many patients who are anticoagulated.
Yeah. So now we've rolled that last lobe up, and you can see we've got a widely patent fossa. And then the key before morcellation is making absolutely sure you have excellent hemostasis. You need to be able to see, you want to see that tissue floating on the morcellator. You don't want to see blood swirling in your face. I use dual inflow irrigation for this. So I have one inflow on the top, one inflow on the bottom, and then my suction from the morcellator is what our outflow is. Some people only use one. I think it's a little safer to use 2. And I think it protects you from sucking up the bladder. And so that's it. Hopefully I caught us up a little bit.
No, we're pretty good. And there's one question about medication like you just talked about. So if you can answer that, that is great.
So I usually give 1 gram about 3/4 of the way through the enucleation. Some people give it right at the start of the enucleation. Some people do a dose at the beginning and a dose at the end. I just do the 1 gram about 3/4 of the way through. Very few contraindications. Active clot, you wouldn't want to give it. Active cardiac, ischemia or recent stents. There's some relative contraindication for impaired renal function. And it can, for people who have seizures, it can decrease seizure threshold. But in general, it's fairly safe.
All right. Wow, we're all tongue-tied at the end of that for a few hours. This was most excellent. We have people from all over the planet, really, really excellent presentations. I cannot thank my panel members and the AUA enough for all that they put together. I actually love the videos. I just sat there staring at them, and now I really want to play around with PAE. The other ones I've actually done. So thank you for joining us today. Again, thank you to the faculty members, and get on it over to the AUA University.